My name is Jeff Niggs. I'm an assistant professor in the Department of Urology, Division of Urologic Oncology at the University of Alabama at Birmingham.
And I'm Soroush Rais-Bahrami, also an assistant professor at the Department of Urology, Division of Urologic Oncology here at the University of Alabama at Birmingham. Today we'll be talking to you about prostate MRI ultrasound fusion-guided biopsies. Prostate cancer is the only solid tumor that is diagnosed by random or indirect sampling. This is largely linked to the lack of reliable imaging for localizing tumors within the prostate gland. So we move forward by asking whether advances in MRI and other imaging modalities can change this approach.
So the typical diagnosis for prostate cancer is based on the digital rectal exam, the serum PSA or a blood test, as well as a systematic random 12-core biopsy of the prostate, which is based on sampling distinct zones of the prostate, but again in a random fashion.
So we ask ourselves, what role does MRI play in diagnosis and screening for prostate cancer? MRI classically gives a much better soft tissue resolution of findings within tissues like the prostate gland. It is able to accurately diagnose and find different areas of differences within the gland, deep in the pelvis, that are not examined accurately with a digital rectal exam or a nonspecific blood test like the serum PSA.
So the parameters which we go through in this prostate MRI are specific to this prostate gland. So we have different anatomic as well as functional parameters. So there's a T2 weighted scan. There's a diffusion weighted image, which looks at the flow of water through tissue, the Brownian motion of water. There's a dynamic contrast enhanced scan that looks at blood flow as it washes in and washes out of the different areas of the prostate gland specifically. And what we're looking for there is different diffusion patterns of blood flow through both cancerous and non-cancerous tissue. There's also a magnetic resonance spectroscopy scan that looks at different choline and citrate ratios or metabolites within different voxels of the image itself. And these can also specifically show us cancerous versus non-cancerous tissue.
So multiparametric prostate MRI has been done at centers like the National Cancer Institute at the National Institutes of Health. The experience there has been with well over 1,000 patients where we both trained. The magnet used is a 3 Tesla field strength magnet. Endorectal coil and or cardiac body surface coils were used to optimize imaging of the tissues deep within the pelvis, like the prostate gland. Multiparametric 3 Tesla MRI of the prostate, as Dr. Nix discussed, incorporated T2 weighted imaging, diffusion weighted imaging, dynamic contrast enhanced imaging, and at certain times, MR spectroscopy. Here on the images you can see areas of hypointensity on the T2 weighted image, hypointensity on the apparent diffusion coefficient image of the diffusion weighted imaging, and then early enhancement on the dynamic contrast enhanced scan.
So the reality is that MRI for prostates has been around for a long time. However, with the advent of newer technology and improved recognition of different sequences and the realities of tissue that is cancerous versus tissue that is benign, has allowed us over the last 5 to 10 years to really get a better sense of those abnormal areas and really improve the sequencing as well as the improved magnet strengths. So classically these were done on 1.5 Tesla magnets. Now with 3 Tesla magnets becoming more predominant throughout the academic centers as well as some community centers, we're able to get a much better image of the prostate, as well as the utilization of different coil sequences. So improved pelvic coils versus endorectal coils to improve that signal to noise ratio that allows us to get such a good soft tissue image. One of the ways that we score these images are specifically looking at each of these different sequences. So we can develop a Likert type scale to look at each of these different sequences and say, is this positive or negative for prostate cancer, so we can objectify this to some degree. And so the radiologist who has years of experience reading these here at UAB, as well as Dr. Rais-Bahrami and I, have been reading these with the radiologists at the National Cancer Institute for a combined 5 years of experience, to look at each of these sequences to say, is this positive or negative, and then add those sequences together to determine, is this MRI saying this is a low suspicion for prostate cancer area, a moderate suspicion, or a high suspicion?
There's different mechanisms of actually using the MRI findings to guide biopsies of the prostate. There's in-bore biopsies, whereby tissue is actually sampled from men's prostates within an MR gantry. Cognitive fusion, whereby men undergo a diagnostic MRI, and then a urologist uses that information and guides areas of sampling to the general area where the MRI had suspicion. And then software platforms have been developed which actually fuse the diagnostic MRI to the real-time transrectal ultrasound that we're all well acquainted with in the office setting to guide the needle cores to the areas of suspicion identified on MRI. This demonstrates a case where a patient underwent multiparametric MRI of the prostate and subsequently targeting a specific area of concern which was of high level of suspicion demonstrated high-grade, high-risk disease.
So again, one of the main differences you highlighted, I think, appropriately, is the difference between the MRI ultrasound fusion targeted biopsies and the different platforms that are available, which we'll discuss in just a moment, versus the cognitive biopsies. And there's more literature on this as MRIs become more prevalent of patients with prostate, is that can you accurately target an area on the MRI without additional equipment or software in the biopsy suite itself? So can I take an area in the right anterior part of the prostate that I know looks suspicious on the MRI, and can I cognitively fuse it? Can I know in my mind, okay, well, I'm just going to sample more in this part of the prostate? And Soroush, if you could elaborate somewhat on that, on what details have been shown in those studies.
So many centers have actually done cognitive fusion, whereby they use the diagnostic MRI, which gives the same valuable information, but then the urologist actually does target extra needle biopsy cores to the area where they assume, based on the diagnostic MRI, they can obtain more tissue samples. There is data supporting that that does better than random biopsies, which were previously done for the past 2 to 3 decades. However, there are software platforms that allow for real-time imaging done by transrectal ultrasound to be snap fused and alter exactly where the targets are on previously performed diagnostic MRI. It essentially gives somewhat of a flight simulator to the urologist to give a target of where exactly to land that needle biopsy core.
And so the cognitive fusions can perform better than the randoms in and of itself, but there's also some data that suggests that the fusion software platforms can improve that even to another degree, which makes sense to me thinking about the process as well. And so the workflow for what you'll see is the patient will come in, they'll get the multiparametric MRI, we'll look at the prostate in a multidisciplinary conference where Dr. Rais-Bahrami and myself, as well as our radiologists who are experienced reading these, will look at these together in a conference platform and determine lesions of significance if there are any. And then the patient will come into the biopsy suite in a urologist's office, which is just like the typical biopsy that they've had before experience-wise. The reality, though, is behind the scenes we're using this technology, we're using this software that we're part of developing, and we're using this to be able to fuse that MRI image with the ultrasound image we create and get a real-time target so that we can accurately target those areas of concern on the biopsy for those patients.
So why fuse MRI and ultrasound? Takes the best from each of these imaging modalities. It uses the fine spatial resolution of soft tissues that MR provides. It also incorporates the high sensitivity and specificity which has been shown on MRI in identifying areas of cancer versus benign tissue within the prostate gland. But then again, it uses the transrectal ultrasound, which is very cost-effective, and temporal resolution in real time is available in all urologist offices for standard biopsies that they've been performing for the past 2 to 3 decades. So the MR ultrasound fusion-guided biopsies are an office-based local anesthesia procedure. There's minimal additional patient discomfort for significantly added diagnostic yield because we're now incorporating those MR images. It utilizes widely available imaging technologies, as Dr. Nix discussed. And urologists are already trained in transrectal ultrasound-guided biopsy procedures, which is their routine. This is all behind-the-scenes software fusion that allows for this higher yield in biopsy results.
And I think some of the misconceptions highlighted are that this is an office-based procedure. This doesn't require anesthesia for patients undergo general for this procedure. The local anesthesia we provide is very similar to what was provided previously for the last 20 to 30 years for patients to undergo this. So again, the patient experience for this biopsy is no different, but what we're doing behind the scenes, the software advances to be able to get a good target, a non-random, if you will, sampling of a patient's prostate to accurately stage their disease is what's paramount in the difference between this and what has been done. And I think that's the real benefit to the patients, as well as its applicability to the field as a whole, is that what the urologist does is not different markedly from what they have done before in their ability to provide these biopsies to patients, these advances to patients in an office-based setting.
Here on this screen, we show a split screen of the transrectal ultrasound with the simultaneous fusion to the T2 weighted image derived from the diagnostic MRI the patient had done a couple weeks prior. As you can see, there's a target which was previously denoted by one of the MR radiologists and ourselves in the multidisciplinary conference in the lower part of the screen. That's identified, and it is snap fused to the real-time ultrasound that is performed that actually guides the needle core into that target.
And again, this is just another screenshot of the image-guided procedure, and what you can see here is a real-time diagnostic biopsy at a specific MRI-defined target, which is what's of great significance and of great difference from what has been done previously. And as we go to the next page, what you see is the software. As we're going through this, we're able to segment the prostate based on the real anatomic prostate images and then fuse that to the ultrasound in both a rigid and an elastic registration setting, because this gland is not rigid. There is some deformity to it, which is something that the software as well as the clinician can build into their procedure.
As you can see here, the imaging performed by MRI in 3 different planes. The axial, the sagittal, and coronal imaging is segmented as Dr. Nix described. This allows for identification of areas along the edge of the prostate, as seen here. In that right peripheral zone of the prostate, there's an area of suspicion which was identified on MRI. This patient underwent MRI ultrasound fusion-guided biopsy with demonstration of a pathologic finding of cancer in that targeted region. And subsequently, the patient went on to a radical prostatectomy, one of the surgical options for definitive management of their prostate cancer. And the area that's denoted on the specimen on the screen there is the area of cancer that corresponds directly to the area of imaging done months before.
And what you'll see is one of the things that I think is so great about how this technology was developed is it was developed as a true research collaboration between the National Cancer Institute as well as the Philips Corporation, which is the platform that we use, and there are others commercially available. But we really did our homework on this, is that the initial technology was developed. We first made sure that we could correlate what we're seeing on the biopsy with what we see at final pathology, and the correlation was 95% or higher, and that has been validated in other studies as well, of what the MRI says is a lesion is what we see at final path. We were able to validate that our ability to detect, infuse, and biopsy where we think we're biopsying based on the ability of our probes to track that location was validated in multiple different parameters. So this then led us to bring this commercially to the market, where the Philips Corporation did, rather, and so that we can get this technology out available to patients in a broad spectrum of locations, not just at research institutions or select academic institutions throughout the country. But what we see is our cancer detection efficacy went up, so overall cancer detection rates are higher with this technique versus just a random sampling. The other important thing is that we just don't want to detect more prostate cancer. As we will allude to in our other discussions on this, is we don't want to detect all prostate cancers necessarily. There is some very clinically insignificant prostate cancer. We also want to improve our detection of clinically significant or high-risk prostate cancer.
Cancer detection rates, as mentioned by Dr. Nix, have been higher in patients with higher MR suspicions. Again, the different parameters on the MRI performed look at anatomic findings as well as different functional findings. And based on those, we can give cancer suspicion to any given lesion or area within the prostate gland. As you can see here, some of our research in the past has demonstrated that higher suspicion lesions have demonstrated higher cancer detection rates when analyzed by individual needle core, the lesion based on MRI findings, and patients overall, with percentage of patients identified with cancer given a high-risk lesion on MRI in excess of 80%. Apparent diffusion coefficient, that's the calculated quantification of the diffusion-weighted imaging, actually has been found to correlate with prostate cancer grade on the biopsies. That, along with MR spectroscopy positivity, significantly more common in primary Gleason 4 or Gleason 5, which are the higher risk, higher grade diseases. This was shown in that same study whereby MR suspicion scores were also predictive of finding higher grade cancers, whether it be intermediate or high risk disease based on the Gleason score on targeted biopsies.
And again, as you'll see here in the graphic representation of what we said, is high-grade prostate cancer detection is improved with this technology in patients with high suspicion lesions versus moderate suspicion lesions versus low suspicion lesions. It allows us to look at these in a real quantitative way for patients. So if a patient, for example, came back, MRI had a high suspicion lesion, it was a very small lesion, and for whatever reason on the MRI ultrasound fusion biopsy we might have missed that lesion, we're so confident in the platform at that setting that we would have those patients come back for a repeat biopsy and we would find that they truly did have high-grade disease. And so these MRIs provide us an invaluable adjunct to what we've been doing in the past. And one of the things I'd like to comment on as well is for those of you who are seeing this who are not urologists or patients who see this, one of the things that we will talk about in the broad spectrum is cost. And people will see that we're doing MRIs for these patients and think, well, that has a great cost. And the reality is we'll often see patients who've had 4 or 5 prior negative biopsies that we'll pick up on the first MRI we do on them and 1 biopsy. Sometimes in these patients we'll just do 3 or 4 cores on them because they've had so many prior biopsies. And so the cost in those patients could have been significantly less if you would have done it initially in those patients. The patient who's an active surveillance patient is another good example, who we do an MRI of the patient, do the fusion biopsy. Yes, there's probably an increased cost to that setup prior to the initial biopsy, but actually accurately determining their disease up front and determining their path will improve cost significantly over the multiple biopsies they might have needed over time versus just an MRI image. If one of those patients gets an infection and ends up in the ICU, the cost associated with that, cost to the patient of lost work time. So all those things can make cost equations difficult to perform, and why we think the cost of this up front, as we better accurately stage these patients, is worth it in the long term.
And it provides a personalized approach to each patient's care, rather than simply identifying them at risk based on a serum blood test of their PSA being elevated, which we already discussed could be very nonspecific, not necessarily caused by prostate cancer. And those are the patients that Dr. Nix alluded to that have undergone multiple prior biopsies year after year because the clinician, their urologist, their primary care doc, has a clinical suspicion of them harboring prostate cancer, which the standard of care biopsies oftentimes have missed year after year. And then when they undergo the MRI, and the MRI allows to oftentimes diagnose and target areas that are otherwise missed on the standard biopsies, those patients can ultimately move forward in a timely fashion towards the definitive treatment they may really need.
So again, in basic summary, the workflow for this for patients is they come in, they get a multiparametric MRI of their prostate, and this is on a 3 Tesla magnet, is the typical platform that we provide for patients. These MRIs are assessed in a multidisciplinary group with both the radiology as well as the urology department, with a combined 5+ years experience of reading these. If there are lesions identified that are concerning for prostate cancer, the patient would then undergo a biopsy. This is a transrectal biopsy, as the standard has been for several decades now. This is an office-based biopsy under local anesthesia only. where the patient's experience is very similar. However, the background of what we are doing is very different than the standard of care. And then those patients then would get an answer to their biopsy results in just a few days. So for an active surveillance patient or a patient with prior negative biopsies who's still concerned, this is a very quick workflow that we can get patients from initial MRI to answer in a very quick fashion.
Thank you.